Chair had to step away for the rest of the afternoon, so I will be chairing the next session, and I am going to go ahead and show you the papers that are on it. All of a sudden, I'm technically inept. So we have 3 talks. This is a lightning session. So each of the speakers, we have ample time. Each of the speakers will have about 7 minutes, and then at the end, we'll still have a little bit of time for Q&A. So we'll get started. Sala, are you ready to share your screen and start us off?
Yes, hi, I am actually, but I don't seem to be able to share my screen. The share button is grayed out. I could sign
Here,
out
let
and
me see if I
sign.
can. I'm gonna get you promoted.
I was promoted.
You are.
Yeah.
So I do have your presentation if you would like me to share it.
Yeah, that would be probably best to do right now.
Sure thing. So I will get that going. And just poke me when you want me to change the
Will do. And I hope you guys can hear me, and you can see my share video, my face. Well, first slide. Good afternoon. My name is Zainab Salah. I am a statistician at the Division of Foodborne, Waterborne, and Environmental Diseases. Today, I'll be sharing a presentation titled Invasive Mold Infection, abbreviated as IMI, and the need for improved surveillance. As a disclaimer, the findings and conclusions of this report are those of the authors and don't necessarily represent the official position of the U.S. Centers of Disease Control and Prevention. Next slide, please. A little background on IMIs. They are serious and often deadly infections, especially for people with weakened immune systems. And we are now seeing cases in individuals without a traditional risk factor, which suggests a broader population may be at risk. Even like hurricanes and flooding events increases concern because they lead to more exposure. But it isn't clear how much they contribute to AMI cases. Despite the risk, there's no national system to track IMIs. Existing tools, in fact, rely on outdated and overly strict criteria that may miss many cases. In this study, we use machine learning methods. I'm still, on this slide. In this study, we use machine learning methods to find which clinical and exposure-related factors are most helpful in identifying IMI cases. The goal was to support the development of a better public health surveillance system that captures both typical high-risk patients as well as those that might be overlooked. The goal of the study was not to guide clinical diagnosis, as those have already been well established. Next slide, please. Our study looked at medical records for patients from 4 different hospitals in Houston, Texas, covering the period from September 2016 to August 2018. That is a short period after Hurricane Harvey. At each hospital, we had 2 infectious disease physicians who carefully reviewed the records and decided the status of each patient, whether they had IMI or they did not. They also classified patients into 3 groups. Those 3 groups are mentioned there in the slide. They were proven or probable cases. Then we had the surveillance cases as well as non-cases. In our study, we did 2 comparisons. We compared the IMI cases, proven probable, and surveillance cases versus the non-cases. And then in the second comparison, we excluded those surveillance cases and we just compared IMI cases, proven or probable versus non-cases. Then we also had subject matter expert who identified 41 variables believed to be important in IMI cases based on literature. And these variables were organized into 4 groups: host factors, clinical features, as well as mycological evidence, and finally diagnostic and healthcare features. Our final data set included 537 records in total, 96 of which were classified as proven or probable cases, 86 were classified as surveillance cases, and the remaining 355 were classified as non-cases. Next slide, please. We performed 100 iterations of lasso model using 5-fold validation to select the optimal lambda. Within each iteration, we randomly sampled training and test data sets, and then we computed the prediction error by averaging across all iterations to assess accuracy and predictive power of the models. We also looked at median number of selected covariates and the frequency of the selection over the 100 iteration. And similar to lasso model, we also ran 100 iteration of random forest using randomly selected training and test data set. We found out that 500 trees were sufficient to stabilize the prediction error, but for the M-trie, we allowed the model to select the optimal M-trie for each in each iteration based on the lowest OOB error. To better understand the relationship between the features and our outcome of interest, we used two feature importance methods, and those were leave one covariate out, or LOCO, and permutation feature importance, or PFI. Both methods follow a similar general approach. In LOCO, we remove one feature at a time, and we reassess the model performance. In PFI, we actually shuffle the values of the feature between the observations, and then we reassess the model performance. Next slide, please. For our result, we found that lasso model had average prediction error of 13 to 15% for the two comparisons. Random forest models perform slightly better for our sample, with prediction error around 12 and 14%. In the chart, we've included the result of the four models: lasso, random forest, LOCO, and PFI, for the two different comparison. And I apologize, the chart is very small and may be hard to read, but I'll try my best to explain the main takeaways. In the green boxes, we found that receipt of systematic antifungal medication and ICD codes were the consistently identified as a key predictors in the IMI case status across all four methods. And their removal led to a significant decrease in the model performance. Positive histopathology also showed strong predictive value in 4 of the 4 methods. But interestingly enough, several non-IMI risk factors highlighted in the yellow boxes, such as neutropenia, cancer diagnosis, transplant, and immunodepressive therapy, were all found to be not important in predicting IMI cases. And for some of them, when we removed them from the model, the model had a better prediction than when they were included. Next slide, please. In conclusion, machine learning model can enhance automated IMI surveillance by providing strong and consistent prediction and case status, helping to streamline the identification process. Real-time identification through model could improve public health response by enabling faster and more accurate detection of cases. These findings also call for rethinking the reliance on traditional IMI case factors in diagnostic algorithm, emphasizing the importance of including non-classical factors to better capture the spectrum of the infection. And finally, the last slide, please. In closing, I would like to acknowledge our colleagues at the 4 participating hospitals in Houston, as well as my team in the Division of Foodborne, Waterborne, and Environmental Diseases at CDC. I also would like to mention that our work was recently published in the Journal of Infectious Disease, so please feel free to look at it if you're interested to learn more. I truly appreciate the opportunity to share our work with you, and thank you for your time and your attention.
Thank you very much, Z. And Ian, Lee, are you ready to share your slides?
Yes. Am I able to be heard and seen?
I can hear you and I can see you.
Great. Then the next step naturally would hopefully be that you could see my slides.
Sweet. Oh, there they are.
All right. Are you able to see them in presenter mode or?
It looks like it's presenter mode.
Okay. Great. So you can't see any of my notes or any of the formatting.
Yep, it looks great.
Great. Okay. Excellent. Go ahead and get started then. All right. Hello, everyone. My name is Ian Lee, and I'm presenting on some research that we've done. So this is using simulation techniques for variance estimation of the census low response score. And I want to thank Ralph Culver for his support on this project, as well as my supervisor, Luke, and my countless other LRS colleagues. And I know this is a lightning session, so we'll go ahead and jump right into it. So we'll start by asking, what is the low response score? The low response score, or the LRS, is the predicted self-non-response to the decennial census. So that is the risk that a respondent won't respond in the next cycle, right? We use this score to determine which areas or communities to allocate more resources and support to. It's based on an ordinary least squares regression, and it uses decennial and ACS estimates from the planning database. So then what's the problem? Well, currently there aren't estimates for the margin of error in the low response score like there are for your ACS estimates. And understandably, this has a pretty, this can be a pretty important measure for assessing the data quality of your estimates, especially once you start drilling down into those lower geography levels, like at the block group level, where you may have some, wilder variance there. All right, so then how do we approach a variance estimation in this case? Well, we don't have an MOE for the LRS inherently, but we do have, some margins of error for the LRS's inputs. So why don't we try simulating some of the possible values that the inputs could be based on the measurement error in their estimates? And then we can run what are called Monte Carlo simulations. And by using the variable's ACS estimate as the mean and using its margin of error in order to calculate, the standard error, we can generate a vector of some, arbitrarily large number, not arbitrary, but some X number, say 10,000, right, of possible values. And then we can do that across all the variables, generate 10,000 values for all of those. And we can use those vectors of simulated inputs to calculate 10,000 possible LRS values. Then we can take the summary statistics of that distribution, and then we can infer variance from it. So I'll drill down into a more visual example. So I'm going to use this example formula, z equals x plus y, right? So we'll have an estimate for x and an estimate for y, and then we'll have margins of error for both of them. So based on that, let's run some simulations. So we draw from a hat, and our first x, we get 18 as our x1, and for our y1 we get 6. And then if we are to use the formula, we put the z1 together and we get 24, right? We pull from a hat again for our x and our y2, and then we can calculate our z2, so on and so forth. We do many iterations. In this case, let's say we do 10,000 iterations, and we get to our 10,000th z. And now once we have all of those values together, we can form a distribution of those simulations, right? So this is a histogram showing that. And you can see the different example z values that we calculated earlier. So in that sense, we have a great way of getting a reasonable sample size of data, where otherwise, you would only have the aggregated estimate or just a singular value. So there will be further analysis incoming and more to do on our side. But for now, I'm going to talk briefly about tracked results so far, and I'm going to use New Jersey as a sort of interesting example for analysis. So first, we have the overall mean variance of the tracts as 1.54. For New Jersey, it had a mean variance of 1.74, which was higher than the mean over the rest of the country. And then I further took an example tract from Passaic County to analyze, and then broke the variances down from tract level to their respective block groups as well. So in that tract, we saw a variance of 1.96, but then breaking it down to its 3 block groups, we saw 7.5, 4.8, a bit higher. And then we had a notably very large 80.5 for its variance. Right, and of course, we expect some increased variance when we drill down to that lower geography, but there's clearly, some sort of outstanding circumstances that has caused this block group to stand out from the rest of them. So that's an example of something that we can analyze and look at further and really drill down to when we have these measures, right? Now, a lot of these numbers, of course, will be more interesting in the future in further analyses when we start looking at response thresholds and comparisons between states or between tracts or counties, whatever it may be. But this is just a great example of what this type of error estimation could provide for us and how we can find potential red flags in the data. So in terms of next steps that we have a few immediate goals in mind. So firstly, this exercise was only carried out across the 2021 planning database year, and that used ACS 5-year estimates from 2015 to 2019. So we'd like to branch out, cover more years, reproduce this exercise, and maybe compare as a function of time and see if there are trends changing in the data. We'd also like to make use of the new low response score methodology that we have on the horizon, which will be adapting the 2020 decennial based variables and modeling based on those. So we'd like to adapt what we have here and iron out the kinks and work through and get everything synchronized on that front as well. Some interesting work could also come from analyzing tract and block group estimates and comparing them to each other, and really getting a grasp of how much, it'll give us some insight into the data quality differences between the two levels, and also when it's valuable to get that higher specificity that you would in the block groups versus the more stable estimates contained within the tract level, right? And finally, we still have some room to improve on this methodology or try different things. So we could experiment with ideas like varying coefficients in, if there is, for example, error in the possible coefficients and not just the inputs, or any combination of the two. But with all that being said, I want to thank you for your time and your presence, and I've left our contact information here if you want to get in touch, ask questions, discuss this further. So thank you, appreciate it.
Great, thank you, Ian. And there was a question in the Q&A, and it says, does your process account for the sampling error in the predictions, tract and CBG level estimates, which always have a lot of noise?
Let me see the question. Yeah, so actually that sort of addresses the next step that we were interested in. Yeah, so yes, it accounts for the sampling error in the inputs is, I believe, what the question is asking. And then the further analysis that we would be interested in is carrying that forth and then seeing if the coefficients, when we initially model the LRS, if we could, find potential, differences or interesting analytical points, looking at those and how we could simulate those and carry that forth. I hope that answers that question.
Yep, thank you. So our final panelist on this session is Ariana Bardao. I'm sorry, I am like totally slaughtering your name there. And Dacio Martinez. Are you guys ready to share your screen and take it on?
Can you hear us?
I can hear you, Dacio, but it looks like Ariana is still muted.
Can you hear me?
Yes.
Yep,
And
can hear
can
you
you
now.
see your slides?
And we see your slides, so you are good to go.
Perfect. Thank you. Hello, everyone. It's a pleasure to be here today. Thank you for having us. Let us first introduce ourselves. My name is Dacio Martinez. I'm a data analyst. I'm working for the government of City of Buenos Aires. We are part of the Health Information and Statistics Office, or GOGIES for its acronym in Spanish.
And my name is Ariana Bardawil. I'm a data scientist, also part of GOGIES. What we'd like to present today is the automatization project of the SUMAR program. As we know, public healthcare systems face growing pressure to do more with fewer resources. So cost recovery programs can play a key role in supporting sustainability in the long term. This topic is particularly relevant because it shows how an administrative process optimized through data science and open source tools like R can have a positive impact on public health institutions. Before diving into the technical details, let me quickly place our team on the map. On the right-hand side, you'll see a short clip zooming into the autonomous city of Buenos Aires in Argentina. And on the left-hand side is a simplified org chart that shows where our office, Information and Statistics Management, fits inside the Ministry of Health. To understand why the SUMAR automation is so valuable, we first need a quick tour of Argentina's healthcare landscape, which is fragmented. We can identify the three subsectors. Firstly, public sector, a network of national, provincial, and municipal hospitals that guarantee free universal care regardless of insurance status. Secondly, social security sector, payroll-financed obras sociales that insure formal workers, plus special funds for retirees and people with disabilities. Coverage here is mandatory for anyone in formal employment or receiving a pension. Thirdly, private sector, voluntary prepared plans that individuals can purchase on top of or instead of the other two. And here we are. In this context, SUMAR is a national program that was created to support the uninsured population by strengthening the public subsystem and providing financial incentives to help providers each time they detect a new patient with public coverage alone. The central axis is a result-based funding model that allocates resources based on service provision and health system performance. The funding comes from the World Bank and is transferred to jurisdiction based on three key components: identifying individuals with public coverage alone, delivering essential health services known as basic effective coverage, and achieving health outcomes measured through key health indicators. Before automation, some healthcare providers in the SUMAR program were had staff dedicated to recovering reimbursable costs. However, this was a complex administrative process, highly dependent on manual inputs, which often leads to frequent errors and missing data. Moreover, many providers had no such staff at all, resulting in no billing records whatsoever. The process involved two main stages. First, during the manual enrollment, health professionals had to ask each patient whether they had health coverage. If not, the patient was manually enrolled using specific software. Today, this step is fully automated through real-time verification with the National Health Coverage Registry, which allows for the automatic identification of beneficiaries. Second, in manual services reporting, data on services provided was extracted manually from paper-based medical records, often incompletely. Administrative staffs then enter information related to diagnosis, procedures, and health evaluation, but the processes lacked consistency and completeness. Now, this service registration process has also been automated by mapping consultations to the services included in the program and applying predefined selection criteria.
In Buenos Aires, our team at GOGIES plays a central role in automating this process. We focus on identifying patients with prioritized conditions and verifying the health services they receive based on records from the health information system. And we also focus on detecting the relevant services that are included in the program to be reported by text mining, using special expressions or regex to reach those records. Another important part of our team's work is to develop and evaluate these regex for the correct data. The main outputs of our process are PDF invoices, weekly Excel reports, and performance indicator summaries. These are generated through three key stages: enrollment, detection of basic effective coverage services, and analysis of health performance indicators. To work with all this information, we count on our own data infrastructure and tools. We have a dedicated RStudio server used by the data science team to automate processes and generate reports. We also use GitLab for version control and collaborative development. All the data we use is stored in a dedicated data warehouse, which we access through dbPlyer. This allows us to query tables, transform data, and prepare it for reporting and analysis. A key component of our workflow is an internal R package called a Heiser that we developed. It includes custom functions to process data. We also use libraries such as Markdown, OpenExcel, Janitor, and Stringer. Also, we use OnCloud as a secure file sharing platform to distribute the outputs across the ministry. We opted for open source tools, not only because of the flexibility and the strong community support, but also because of the cross-functional team. The open source ecosystem, particularly around R, has a more accessible learning curve, which enables professionals from different disciplines to collaborate effectively. Here's how the process works from end to end. In Buenos Aires City, the hospital management system known as IGEOS is the main source of data for the public health subsystems. We start with the medical visit record in IGEOS during the reborn period. Then we check, does this patient have public coverage alone? This is based on two records registries, the National Health Coverage Registry called PUCO and the SUMAR registry. If the answer is yes, we apply regex and logic rules across multiple data sources to detect eligible health services. We enrich each case with reportable fields like vital signs and anthropometric values. Then, using our Markdown, we automatically generate the required PDFs and tabular files for submission. These files are delivered back to the health providers by OnCloud. If the patient doesn't meet criteria, the visit is excluded. This pipeline runs centrally in R using Tidyverse, Stringer, by Excel, and Tiny Text, so it's open source, reproducibly, and full auditable. Finally, this time series shows the number of health services detected automatically from January 2021 to April 2025. What stands out is the steady increase in volume, not just due to more services being delivered, but because our optimization has become more robust, scalable, and comprehensive. Every dot here represents real services for real patients turned into real funding for the public system without manual intervention. It's a clear sign that optimization doesn't just save time, it also expands coverage and strengthens accountability. Thank you very much.
Talk about like just cutting it right to the wire. Good job. We just have just a couple of questions for, or a couple of minutes for Q&A. Does anybody have any questions? Perhaps the panelists have questions for each other, for example. Let's see anything in the Q&A here. Okay. Well, thank you all very much. Great end to a first day. And I'll kind of come back on. We just have a couple of announcements on this, at the end of our first day and before we go into our workshop.